Musculoskeletal tissue. So let's start with Enid. Enid, what is a dense, hard connective tissue that forms a skeleton?
Do we know? Oh, Jackie.
Wait, she just we don't have an instructor in here, we're just kind of listening.
So I shouldn't ask you questions? Okay,
Yeah, they'll do that.
Thank you for telling me that though. Okay, Tonkawa, take that one. Bone is the first one.
I guess she could answer this.
Yeah. Stillwater, what is dense, non-vascular connective tissue that covers bones to reduce friction and destruction? Cartilage is right.
What did I say?
Tonkawa again, what is the space where two bones come together that may or may not be movable? Joint is correct. Stillwater, what is a flexible band of fibrous tissue that binds bones together to form a joint?
Tendon.
I think I heard it. What was it?
Tendon.
That one is actually ligament, I think. But it's almost time, so you can do the next one too. Dense band of fibrous tissue that attaches a muscle to a bone. What's that one?
Tendon.
Tendon, yeah. Tonkawa. What is striated muscle that connects to bone and is under voluntary control called? Or what is it? Skeletal muscle. Stillwater. What is the fibrous membrane that covers, supports, and separates groups of muscles, encasing the muscle's blood, lymph, and nerve supply?
Fascia.
Fascia is right. And Tonkawa, back to you. Clear viscous fluid secreted into joints to provide lubrication and shock absorption. Synovial fluid, yeah. Good job, guys. Fascia is F-A-S-C-I-A. Everybody caught up on writing? Okay. Most of these I filled in. So, looking at bones more closely, they can be classified by their type. We have long bones, which are typically our weight-bearing bones. You can think of an example of a long bone. Femur's a good example, yep. We have short bones that bear little or no weight. So you can think of an example of a short bone.
Fingers.
Yeah, that's good. Or like also metatarsals and tarsals, like finger and toe bones, don't bear a lot of weight either. Next, we have flat bones, which protect our vital organs. Stillwater, example of a flat bone that would protect something. I cannot hear you guys very well. Say that again.
Sternum.
Sternum is a good example, yes. It's a flat bone that protects the vital organ. And then we have irregular bones, which are uniquely shaped based on their purpose. And those can be things like the little bitty bones in the inner ear that have a very specific shape, so they can do what they're supposed to do. A lot of this is just review a little bit before we get into disorders. Bone has two layers. It has a cortex, which is dense, compact outer layer. Tom, what does the cortex do for your bones? What does that dense hard layer do? Protects, right? It's going to protect and give it, what's the word? Make it firm so that, and rigid, I guess is probably a better word. Make it rigid so it can hold its shape, even under pressure. So then we have the medulla, which is the spongy, porous inner layer. Inside that layer, we have the bone marrow. We have red marrow, which manufactures and releases red blood cells, white blood cells, and platelets. And then we have the yellow marrow, which contains fat cells. And both of those kinds of marrow are going to become important to us as we go on in this lecture. A couple of other just general facts about bone. Bone is very vascular. We don't necessarily think about it being that way, but it is. Has an estimated blood flow of 200 to 400 milliliters per minute through our bones. And each one has a main artery that provides nutrition for the bone tissue. Has very few nerve endings though. Bone reaches maximum maturity and maximum growth after puberty. In healthy individuals, bone is continuously and consistently remodeled. So it's constantly being broken down and rebuilt until about the age of 35 when the breakdown starts to exceed the rebuilding. And so that's why we see more fractures as people age, the bones being weaker. This time kind of just talk about bone remodeling. Bone remodeling is going to be based on the body's needs and hormones. So depending on whether a person is weight bearing and exercises versus immobility, depending on what kind of electrolytes and minerals are available for the body to build with, what kind of disease processes are going on. And it involves osteoblasts, which form bone, and osteoclasts, which destroy bone. And I think that's like counterintuitive when you read those words, like you want a blast to destroy the bone, but that's the opposite of that. So you have to kind of remember that. Yeah, like you're blasting it with a welder. That might work, sticking it together. How does bone change in the older adults? And I didn't put the arrows on here because in another lecture, the arrows were confusing to people, like it was hard to see them on the screen. And so sometimes people wrote in the wrong direction. So I kind of left them off and we'll just go through because they're pretty quick to write. So osteopenia, decrease in bone density. So that would do what to the risk of fractures for these clients? Right, so that's going to increase the risk of fractures. Stillwater, what do we do about that as nurses? What are some things we can do?
All precautions.
All precautions is important, exactly. Is there anything they can take to help with that?
Vitamin D.
Vitamin D and calcium, yep. Those things can help. What about activity? Is weight bearing good or bad for bones? For healthy bones, I guess I should specify. Yeah, weight bearing is good, makes them stronger. So that's another thing they can do. And we'll talk later when we talk about osteoporosis that just like consistent regular walking is actually the best thing that you can do, especially when you're younger, to prevent osteoporosis when you're older, is to keep those bones consistently used, basically. As people age, bones become more prominent. So what does that do to our risk of skin breakdown, Tom? Right, so you have an increased risk of skin breakdown. So we're gonna do frequent position changes, use pads and airbeds, eliminate other factors that will increase skin breakdown, such as moisture, nutritional deficits. You wear those things. So changes in posture, gait, and mobility can lead to skeletal deformity, decreased thoracic cavity, a slower gait, and which direction would the risk of falling go? Increase. So we've got an increased risk of falling and an increased risk of fracture. So that's why that becomes so important, all those safety measures in older adults. Another intervention for this is working to correct poor posture early, because poor posture can over time cause that skeletal deformity that's going to throw their balance off further and make them more prone to falls. Cartilage degenerates. We talked about the role of cartilage in protecting bone and kind of making those movements easier. So as that degenerates, we get joint damage, joint pain, and decreases in our range of motion. Then in turn, that decreased range of motion is going to cause us difficulties with ADLs, even bathing and dressing. They get muscle atrophy, which is going to decrease strength and coordination and strength, and increase their dependence on others to do things for them. We can teach them isometric exercises that help maintain what the range of motion they have and the muscle strength that they do have. So I think we talked about that when we talked about older adults. The less active that they are, it's kind of a vicious cycle. Basically, that gets worse a lot faster. So we want to keep them active, keep them moving their joints. That resulting slowing of movements can cause interpersonal conflict and lowered frustration tolerance. They get frustrated as nurses, and I think we talked about this too with older adults. We want to allow them time to do the things that they can do. Because once again, the more active they are, the more active they're going to stay. And sometimes we want to just jump in and do something for them because it's quicker and it gets us out of the room. But we really want them to do everything that they are capable of doing on their own, so that helps them remain independent longer. The next slide is a summary slide, and I've kind of tried to shorten this lecture a little bit, so we're going to skip it. I'm going to talk about most of it, but there's nothing you need to know off that one. Next up Osteoporosis, does anybody have any questions over that, like kind of review stuff so far, A&P stuff? Okay. Osteoporosis is the first thing we're gonna talk about. Chronic situation where the osteoclastic activity is greater than the osteoblastic activity leads to bone loss, bone density, produces a decrease in bone mineral density. Decrease for that one. Results in thin, fragile bones that fracture easily. There are two types. And primary and secondary in this case mean kind of what they do every time we talk about them. Primary means that it kind of starts out with the actual osteoporosis itself, so it's due to the actual osteogenic activity, the activity of those cells. Secondary means it comes from something else, some other condition, some medicines they're taking or something like that. Risk factors. Age and gender. Women typically start to develop it after menopause. Men wait a little later. Men can get it, but it's usually after the age of 75 before they start to develop it. This is due to the difference in hormonal changes and the speed with which that affects bone mass between the genders. Genetics are an important factor in osteoporosis. A parental history, especially of the mother, is a major factor. Heredity rates are estimated to be as much as 50 to 90% on osteoporosis. Body build and weight can affect the osteoporosis risk. So people who are thinner or lower weight, thin builds, low weight, may have more trouble with osteoporosis. I added in, and I tried on these slides to orange everything that I was either adding in or was like a blank I was filling in, so you guys would notice, and I remember to touch on it when we went through these. Nutritional factors I added here. Other nutritional factors that you can write down are excessive intake of caffeine or carbonated beverages can affect osteoporosis risk. A diet that is excessively high in protein can increase the risk. A lack of vitamin D absorption can increase risk. And we'll talk about that a little more. The next disorder is primarily related to vitamin D. So there are several ways that can happen. Either I'm not taking enough in, for some reason I can't absorb what I do take in, also because I'm not getting exposed to vitamin D by sunlight can be some of the ways that we end up with that vitamin D deficiency. And then like it says, the next one is any disorder that can cause malabsorption of either calcium or vitamin D can contribute to this. Activity level is important, like we talked about. Weight-bearing exercise strengthens those bones, so a lack of physical exercise or prolonged immobility is going to make those bones weaker. Tobacco use is a problem, whether it's active or passive. And both alcohol and tobacco increase acidosis, which increases the bone loss. And in addition to that direct effect on the bone, it also tends to inhibit people's nutritional intake. So then they're also, so their bones are kind of, I think it's a double whammy. Their bones are not, well, they're not doing well to start with, and then they also don't eat and drink properly, so they don't have enough calcium and vitamin D to rebuild. So what do these clients look like? What do we see? It's often a silent disease. People don't know they have it until they break something. First sign is often a fracture, especially after the age of 50, a low trauma event. It's oftentimes the first time that somebody gets diagnosed.
Mrs. Hagan, I think it's
Yes.
a question.
Okay.
You said increased acidosis leads to increased bone loss?
Yes.
Okay.
But you don't so much have to remember that detail as long as you remember that alcohol and smoking is bad for it. What else? Most common fracture sites with this disorder are spine, hip, and wrist. Hip fractures can be particularly debilitating in the older adult because it decreases the mobility so much. So there's a very high mortality rate in the year following a hip fracture for an older adult. We'll touch a little bit on Dowager's hump or kyphosis. And there's a good visual, if you don't know what that is, in your book, I've got written down page 1018, has kind of a little picture that shows you as a person ages kind of what that might look like. Clients may experience a loss in height. They may have back pain, especially with movement, which is suggestive of them having little fractures in their vertebrae from them being weakened. And then often clients will self-restrict movement because they're having that pain in their back. So then what's gonna happen if they stop moving because that hurts? You know, they get stiff and their bones just get weaker because now they're not doing anything weight bearing because their back hurts all the time. Clients may also become so afraid of falling that they limit their activities, which also leads to less weight bearing and just kind of perpetuates the disorder. Okay, there are 3 slides in here on diagnostics. I really tried to kind of trim things down so we had more time. So what I'm going to tell you is these 3 slides you can mostly disregard. I want you to know a little bit about diagnostics. Basically, I want you to know there's no definitive lab test that is going to tell us whether or not somebody has osteoporosis. Some lab values can give us an idea how quickly they're turning over bone, and we can maybe use them to help monitor the effectiveness of our treatments, but that's not how we diagnose it. We diagnose it by looking at bone mineral density measurements, and there are several methods we can do that. As far as the exam, as long as you know that's kind of generally what we're doing, you don't necessarily need to know the details of every single test. You can kind of read over these slides, but you don't need to memorize all of it. So I'm gonna skip through those. Bone mineral density exams. And there are several different kinds, they're in those slides, but overall, that's how you diagnose it. How do we treat it? So, like I said, likely the best defense against osteoporosis in later life is building strong bones as a young adult. That's important since lots of you guys are young adults, because, you know, you're gonna need those backs and those bones to be nurses until later in life. Fractures, so the first part of treatment is stabilization and treatment of fractures. We're going to talk a lot on Thursday specifically about fractures. You also want to do some nutritional counseling with them, dietary intake of calcium, plenty of protein, vitamin D and vitamin C are all important preventative and treatment measures. So those are all things that are important to our bone health in terms of nutrition. But for those that are lactose intolerant, soy milk and lactose-free milk are still good sources of calcium if you have clients who can't use milk. They can also look at fortified products, like breads and cereals that are fortified with those extra elements. If they can get at least 5 minutes of sunlight a day, that's gonna help them with their vitamin D.
How many minutes? 5.
And routine monitoring of calcium and vitamin D levels are encouraged for both genders after the age of 50, just to kind of see what our risk factors are looking like. And we talked about caffeine, and we talked about alcohol already. As far as physical activity, we want them to be doing strengthening and weight bearing, I think is your other point there, exercises. We want those to be regularly scheduled. So we want them to be in a consistent habit of doing 3 to 5 30-minute walks a week. And walking is actually literally our best treatment for that, is having them walk. It's safe, they're not, we don't necessarily with clients who are diagnosed with osteoporosis want to encourage them to take up other activities where they might get hurt, but walking is a very low impact safe thing for them to do. Swimming can also provide a form of strength training that they're going to be low risk for a fracture in.
Mrs. Haig, I believe that's why we have them pack about 40 pounds of nursing textbooks, is we're doing osteoporosis prevention at an early age.
Yeah, no, that's a good point. Okay, but I can't explain why we have to carry those around because I think we're past.
Yeah, I know, that's how I got my hernia years ago.
Yeah, exactly. I remember way back and that's still not helping. I still have to get it out of the car. Clients with osteoporosis should specifically avoid jarring and high risk for fall activities. Things like jogging, horseback riding, and roller coasters are not going to be good for them. As with pretty much everything, we'd like for them to stop smoking completely if they want their bones to get healthy. And then we're going to look at inpatient fall reduction. That's always important as a joint commission goal, but it's especially important in this particular group because the risk of injury from those falls is really high. We've kind of talked about all these things before: bed alarms, toileting every 2 hours so they're not trying to get up on their own because they have the urge to go. Make sure their assisted devices are within their reach. Walkers are close enough that they can reach them if they need them. They're not trying to reach way out. Same thing with bedside tables. When we get done with stuff, make sure their table is put back right beside them so they're not leaning out of bed to reach for a phone or a call light or something like that. As far as at home, improved lighting, night lights, removing all that clutter, throw rags and things like that on the floor. Wearing rubber-soled non-slip shoes, kind of like what we do in the hospital with the rubbery socks. They have their house shoes by their bed, that helps too at home. Making home modifications such as handrails to get in and out of showers and baths, and in toileting areas will help prevent falls too. Where we're at. We didn't get all the way through osteoporosis. That's okay. We're gonna skip over, it can be basically, we can use surgical stabilization, spinal fractures, in a stable client, but you don't need to know the details on that surgical slide. So read it, but don't memorize it. Pharmacological treatment. So this makes sense to us. They might need calcium and vitamin D supplementation. This is not a sole fix for osteoporosis, but maintaining these levels improves the effectiveness of the other treatments that we're making. Weight-bearing exercise doesn't do them any good if their body doesn't have the nutrients it needs to build that healthy bone when they take on the weight-bearing exercises. So we types, it has examples of what kind. They need vitamin D to help with their calcium absorption, so it's often good to give those together. PO forms, you've got side effects there: hypercalcemia, urinary calculi, constipation, and flatus. They need to make sure that they take it with food and a full glass of water, and they also need to increase their fluid intake. Why do they need to increase their fluid intake, Tombola? Are there any of those side effects that might help prevent? It would help with constipation. Any others? Urinary calculi is the other. So if we keep things moving better, we're less likely to form those things too. They need to take 1/3 of their dose at bedtime. Stillwater, do you know why that is?
For absorption.
Yeah, it basically, the body can use it better when they're at rest. So if they take it all in the morning and then they move all day, the body isn't able to make maximum use of it. So we like them to divide their dosages out throughout the day, and definitely at least take some of it in the evening. The body uses it better when they're at rest. So like if they'll take some of it when they go to bed and then they're kind of not moving, the body can use it better.
Ms. Hayes,
Yes.
are these nursing implications for calcium or vitamin D?
I think just the generally combined supplement of both, because we're generally going to use them together
Okay.
for osteoporosis. Women should start in young adulthood. Once again, hint, hint. And monitor, we need to periodically monitor the levels that they have, because obviously hypercalcemia is a side effect of this medicine. Got 2 more meds. Does anybody have any questions? Because it's 1:18. Yeah. Oh, it is, this clock hasn't changed, huh? It's 2:18. I want to keep you guys for another hour because the clock isn't changed. Questions? Okay, I'll start talking about this, and if we get cut off, we'll go back and start here the next day. Bisphosphonates. These are used to slow bone resorption by binding with the crystal elements in the bone. Got your examples listed there of these medicines. They come in PO and IV forms. The really important thing to remember about these is that they need to take this medicine on an empty stomach with a glass of water, and then they need to stay upright for 30 to 60 minutes. If you look at the side effects, talk a lot. Why do we want them to stay upright? Right, right, because it can cause inflammation of the esophagus. So we don't want them to reflux that back up, basically. So if they stay upright, it helps it stay down where we want it to be. They also need to have a dental assessment and monitoring before and during treatment. If you look at your side effects, it can cause osteonecrosis of the mandible or maxilla. So osteo means bone, necrosis is dead, so it can cause dead bone in their jaw. So they need to be on top of their dental assessments. They're going to repeat their DEXA scan every 3 years to see if it's being affected. And I think this last part I added, they need to check aspirin sensitivity and kidney function before we start this medicine. There are some newer versions where they'd only have to be dosed every 3 months to every year. for people who don't want to do the sitting up for 30 to 60 minutes. But the traditional medicine, you have to be up for 30 to 60 minutes after you take it. I lost it, yeah. Estrogen agonists and antagonists. These medicines are designed to mimic estrogen. So like we talked about, osteoporosis develops when people's hormone levels start to drop with age. So these kind of mimic estrogen in places, but not everywhere, to try to decrease the side effects of taking that extra estrogen. They are contraindicated. There's always a controversy about taking hormone replacement and blood clots, right? Like you guys have kind of maybe not heard that, maybe you're too young to think about that controversy, but anyway, it's a controversy. So it's not surprising that one side effect we see with this medicine is an increased risk of venous thromboembolism. So anyone who for some reason might be at higher risk of that, if they're going to be immobile, they need to stop taking it 72 hours before they're immobile, because that's going to double up their risk on that. We're going to pay attention if they have any calf pain or tenderness. Can also cause hot flashes and breast pain, which makes sense because it's a hormone. Similar things to what you see in pregnancy and menopause. And then I think we'll stop there, because that's all the meds for it. And then we'll start with complications next, because I'm at 2:29. I haven't seen the little one with that.
Sorry.